Now we are coming on to the second session of our post-lunch session. This session is sponsored by Boehringer Ingelheim Pharma, and the topic is simplicity in management of patients with type 2 diabetes mellitus with linagliptin. And our speaker is very eminent endocrinologist who has done DM, Dr. Subrata Chakraborty. He is an excellent speaker and he is an upcoming endocrinologist and he is doing a very nice job in Eastern India. Dr. Chakraborty, please come up and deliver your speech, sir.
So after the last almost futuristic session on radiation therapy, we would be something moving back to the ground. So the current pandemic, and if we talk of pandemic, almost unconsciously refer to the COVID-19 pandemic. But we need to understand, as it's the innate nature of any immune or any communicable disease pandemic, it's likely to be dying down within a span of 1 or 2 years, and that's been the norm with COVID-19. But this one pandemic with type 2 diabetes mellitus, which has probably shown no sign of regression in the last few years, and probably with the current surge in new onset diabetics throughout the length and breadth of the country, we are likely to observe a doubling in the number of diabetics throughout the country. So let's simplify the treatment regimen of type 2 diabetes mellitus and let's focus on some basic facets of diabetic management. So it's formally titled Optimizing Treatment Regimen in a Type 2 Diabetic Individual, and how does simplify make, or how does linagliptin make our job easier? Now, why do we need to simplify? First things first, because when we talk of diabetes mellitus, please remember it's not only a disease, it's a syndrome. Comes with itself a host of comorbidities, starting from dyslipidemia, hypertension, hyperuricemia, obstructive sleep apnea, non-alcoholic fatty liver disease, and a plethora of equally deadly complications. Chronic kidney disease, cerebrovascular disease, cardiovascular disease. Now, what's the clinical impact? The patient would be popping a minimum of 9 to 10 pills a day over a span of 24 hours. So you can well understand, and we should acknowledge that it is taking a toll on the quality of life. So we need to make things easier for the patient if realistically possible, if not encroaching upon the quality of blood glucose control in that particular individual. Now, this would be easier appreciated if we start with a real-world case discussion. So, it's probably a garden variety of diabetic individual, a middle-aged female, post-menopausal with type 2 diabetes mellitus, diagnosed for 2 years. But that doesn't mean patient was suffering from type 2 diabetes mellitus for 2 years, because statistics suggest there's a latent period of nearly 5 to 7 years between the onset of the disease and its picking up by the healthcare provider. Patient was receiving some sulfonylureas. Unfortunately, the blood pressure and lipid profile were a target. Apparently, patient is not having any micro or macrovascular complications, but this scenario might change altogether within a span of 2 to 5 years. A glimpse at the blood glucose profile would suggest that the A1C is 7.6%. Now, are we happy with the blood glucose control? Probably no, because in a patient who's having no end-of-life scenario, who's not having established atherosclerotic cardiovascular disease, or not having repeated episodes of hypoglycemia, according to the global guidelines, the target should be less than equal to 7%. Of course, it should be achieved without incurring higher episodes of hypoglycemia. The renal profile was well within acceptable range, and the patient was previously receiving a standard quota of metformin and statins. So, here's a patient who's uncontrolled on metformin therapy with history of proven compliance. Now, the clinical perception has been doing the rounds even in our healthcare provider fraternity, that linagliptin is not for early type 2 diabetic individuals and probably restricted to patients with late or complicated type 2 diabetes mellitus when the patient has florid complications in the form of chronic kidney disease. So, the prevailing notion is that only when your patient has landed in CKD stage 4, start with linagliptin. There's no point starting linagliptin in a patient who's having a perfectly preserved renal profile. But there's more to the story, because when your patient has already landed in CKD stage 3, or CKD stage 4, please remember the treatment protocol becomes more cumbersome, the pill count increases even more, and still the prognosis remains guarded. The risk of hospitalization increases. So in our medical fraternity, we often use the term prevention is better than cure. And seldom is this premise better exemplified than the case of chronic kidney disease, because we should retard the progression of chronic kidney disease as much as possible, because if the patient has already landed in CKD stage 4, there is very little option to make the patient revert back to CKD stage 2. So renal-friendly molecule should be started as early as possible. That should retard the progression of chronic kidney disease. Now, of course, as an anti-hyperglycemic agent, you should reduce blood glucose. So linagliptin as a single molecule, as well as in combination with metformin, provides wonderful blood glucose control. And the cherry on the top is that these patients have minimal chances of hypoglycemia. So what we physicians are concerned about, that efficacy is not blunted in any way by any adverse parameters or red flag signs. It is wonderfully demonstrated by the usage of linagliptin. The patient harnesses a wonderful, robust and durable glycemic control, and all of these benefits coming at minimal risk of hypoglycemia. Now, the second patient, we are not delving into the details of the patient profile, but overall, please remember, we are dealing with a patient with type 2 diabetes mellitus with renal insufficiency. Now, how common is this scenario? Now, please remember, a patient of type 2 diabetes mellitus almost has 30 to 50% chances of developing chronic kidney disease at any time during his or her lifetime. And chronic kidney disease doesn't only reflect in terms of decline in eGFR. It might well be in terms of alteration of urinary albumin-creatinine ratio. And at least in Asian Indian population, these two arms do not always go hand in hand. You can well demonstrate a discrepancy between these two parameters. A patient might have well-preserved eGFR with a severe progression in urinary albumin-creatinine ratio, and the vice versa is equally true. Both these parameters, a decline in eGFR and a progression of albuminuria, although typically these are microvascular complications, but these are actually a unifying point between micro and macrovascular complications. How so? Because those patients who are having a decline in eGFR, that might be an acute precipitous decline or a chronic progressive decline in eGFR, or in those patients who are having micro and macroalbuminuria, these patients are at higher risk of dying from a cardiovascular event or a cerebrovascular event rather than progression to end-stage kidney disease. So the list of agents which have been found to be both efficacious as well as safe in a patient with chronic kidney disease, and I'm not referring to diabetic kidney disease, this list is pretty small. And linagliptin is one such glorious exception which has been found to be both simultaneously efficacious as well as safe, irrespective of the background eGFR, irrespective of the background urinary albumin-creatinine ratio. And many a times we have seen that a molecule has shown excellent promise in the control trial setting. But when the same molecule is thrust into the real-world scenario, the benefits vanish altogether. Therein lies the importance of real-world evidence studies. And fortunately, in case of linagliptin, there is no such discrepancy between the RWE data and RCT data. Both randomized control trials and real-world evidence studies have overwhelmingly proved that both in a trial setting as well as in a routine clinical care setting, linagliptin is one such molecule which should be in the treatment algorithm when you are dealing with a patient with diabetes with diabetic kidney disease. So this was well demonstrated from the landmark Carmelina trial. I'm not sure how many of you have read this Carmelina trial. This was published pretty recently in 2019, where they considered that linagliptin, even when used in those patients with advanced chronic kidney disease, these patients do not run the risk of landing up into hypoglycemia, leave alone severe hypoglycemic episodes or nocturnal hypoglycemic events, and overwhelmingly superior in terms of glimepiride, in terms of reducing the hypoglycemic events, and more importantly, it retards the progression of urinary albumin-creatinine ratio. It retards the progression from micro to macroalbuminuria stage. Now, how about know that? So this is a new terminology coined. The nephrologists, in a joint collaboration between the Department of Endocrinology and Nephrology, way back in 2016 to 2018, we had conducted a study in SKMA hospital. There was the prevalence of NODAT, because not always diabetic patients land up in end-stage kidney disease. It might be entirely a polycystic kidney disease, untreated, uncontrolled, and these patients landing up in chronic kidney disease. Now, these patients might develop type 2 diabetes mellitus, and this is specific terminology coined called NODAT, new onset diabetes after transplantation. It is equally deadly as your average or garden variety of diabetes mellitus in terms of progression of other micro and macrovascular complications. And linagliptin, even in this specific subpopulation of kidney compromised patients, have been found to be both efficacious as well as safe. Now, patients with hepatic impairment, when we talk of complications of diabetes mellitus, we refer to cardiovascular disease, we refer to chronic kidney disease, neuropathy, retinopathy. Now, how many of us would agree that non-alcoholic fatty liver disease is one of the underestimated and underappreciated complications of diabetes mellitus? Now, is it something numerically small? No. It develops in nearly 40% of our type 2 diabetic individuals. Only if we had asked every diabetic patient to undergo a routine USG, we would have documented majority of the patients would be having grade 2 fatty liver. Do we attach any clinical importance to it? Usually not, but that's the fallacy on our end, because non-alcoholic fatty liver disease has an equal predisposition as alcoholic liver disease to progress to fulminant hepatic failure. Now, if the list of agents which have been found to be efficacious and safe in a patient with chronic kidney disease happens to be small, then the list is smaller in those patients with T2DM with hepatic impairment. And there is a prevailing notion, and we do not blame any healthcare practitioner profile for that, that no OHA or antihyperglycemic agent is safe in chronic hepatic impairment. This is partially true. Of course, insulin happens to be the safest agent, most trusted agent in those patients with chronic liver disease. But in patients who are having Child-Pugh category A or Child-Pugh category B, not having decompensated liver disease, you can still weigh in the option of using linagliptin. Linagliptin in multiple RCTs and real-world evidence studies have been documented to be both efficacious and safe in patients with T2DM with chronic liver disease. So no dosage requirement is required for linagliptin in the patients with both hepatic impairment as well as in those patients with renal impairment. Now, this is probably one of the most glorious exceptions across the entire anti-diabetic agent landscape. None of the other agents, even the most fascinated and the most hyped ones, the GLP-1 receptor analogs, SGLT2 inhibitors, they usually do not have such recommendations from the apex regulatory authorities, but it's only linagliptin in this regard. Now, elderly patient. Now, what's unique regarding usage of anti-diabetic agents in an elderly individual? Here, we are more concerned about safety. Safety is relegated to the center stage, and efficacy is probably relegated to the background, because we can still afford some degree of poor glycemic control, but never an episode of hypoglycemia. Because in those patients, elderly patients aged more than 65 years, they usually have some element of autonomic neuropathy. They are less likely to recognize the warning signs of hypoglycemia and can directly land up in hypoglycemia, hypoglycemic coma, requiring hospitalization, sudden cardiac death due to precipitation of a ventricular fibrillation or ventricular tachycardia. So we need to weigh in the option of the safest anti-hyperglycemic in such patients, and elderly patients often have some degree of renal compromise. So linagliptin is one such molecule which has been found to be both efficacious and safe regardless of patient age. Even in studies, they have shown that even the most elderly patients aged more than 80 years, where the patients often do not recognize the treatment regimen of type 2 diabetes mellitus, still usage of a small dosage of linagliptin, might be 2.5 milligrams of linagliptin, is absolutely advantageous in such patients. The patient doesn't have to remember taking the medication at any particular time of the day. The physician can rest assured that my patient wouldn't land up in an unexpected episode of hypoglycemia. So overwhelmingly, yes, a proven efficacy in patients irrespective of age and irrespective of the duration of type 2 diabetes mellitus. So linagliptin, if we pit head to head all the currently available gliptins in our basket in the fight against type 2 diabetes mellitus, we consider vildagliptin, teneligliptin, linagliptin, sitagliptin, alogliptin in the ambit of today's discussion. Probably we are not including those gliptins which are not available in India, and we can still consider that linagliptin, if we consider all the hard clinical endpoints which are analyzed or which are expected to be performed comfortably from a standard anti-hyperglycemic agent, it is linagliptin which probably ticks off all these parameters safely and comfortably. Either the other molecules are plagued with a problem of paucity of data, or they have been documented to be not safe. Say, for example, the European Society of Cardiology, the apex regulatory authority, the European guidelines recommending the standards of care in heart failure, they have categorically underlined the fact when you are dealing with a patient with diabetes mellitus and heart failure, there are only two options. You cannot consider vildagliptin, teneligliptin. It's only linagliptin or sitagliptin. So these agents should be used and must be used in this Google era, in this litigation-friendly area, when you are dealing with a patient with type 2 diabetes mellitus with heart failure. So our expectation from an ideal anti-hyperglycemic agent, efficacy and safety, cardiovascular safety, the CVOT documentation, and from the patient's perspective, the simplicity, and it shouldn't interfere with the quality of life. So we have well documented the efficacy and safety data in the last 20 to 22 slides. Now from the patient's perspective, usage of this molecule, which requires only once daily administration, can be administered at any time of the day, irrespective of the meal times, and doesn't interfere with the quality of life, poses minimal risk of hypoglycemia. That means minimum chances of hospitalization. So probably this is close to the perfect anti-hyperglycemic agent we have ever encountered in the last two decades. So in those patients where you feel the patient might require a robust and durable glycemic control, in those patients where you feel the patient is vulnerable to episode of hypoglycemia, in those patient subpopulation where you expect patient might land up or has already landed up in chronic kidney disease or atherosclerotic cardiovascular disease, hands down, linagliptin should be in your treatment algorithm. I'm not mentioning that linagliptin should be the one molecule that you need to use, but obviously along with combination of the metformin, along with usage with SGLT2 inhibitors, you should not consider missing the benefits of linagliptin. Thank you for patient hearing. I'll just stop here.
Thank you very much. Dr. Subrata, you have already, in your previous talk, have shown very nicely the use of SGLT2 and linagliptin, and also in this lecture and at this era where Vilda and Sita, because of the patent is gone, it is coming boomingly in the market. I think your talk will give us more thought of using linagliptin for a better use. So thank you very much. And
Thank you very much, Dr. Chakraborty, for an excellent, once again, a brilliant presentation. Excellent, sir. So I would like to request our eminent chairpersons to felicitate Dr. Chakraborty. Dr. Subrata Chakraborty. Session has been sponsored by Boehringer. Thank you, sir.